The November month is in lung cancer awareness month. So because of that, I think they wanted to organize many conferences as well as this webinars. Ultimately, any lung cancer management is something like it is a multidisciplinary approach. So it varies from general physician to pulmonologist, the pulmonologist, CT surgeon, then again imaging, something like a nuclear medicine and radiology, then pathologist, the molecular oncologist, radiation oncologist, surgical oncologist, and medical oncologist. At the end of the day, something palliative oncology also. So many branches are involved in the management of lung cancer. Particularly, this landscape because over the 2 decades of my experience, I have seen a sea change in the management of lung cancer in terms of diagnosis, in terms of molecular pathology or molecular oncology, in terms of again targeted therapy. So many things happened over a period of 2 years. Once upon a time, the survival was only something we used to say 4 to 6 months. Now the people they are living for minimum around 50% people they are living for 5 years now. So there's a drastic change in the management of lung cancer because of it's a multidisciplinary approach and interactive sessions with multiple departments. Ultimately, they are doing a great job in terms of providing the best possible care at affordable cost. So Indian setup is again now there are so many issues, but still every branch, every specialty has its own role. So then only we can I think, make all the people to live longer with good quality of life. Even though it's early stage cancer is curable, for stage 1, stage 2, stage 3A, up to that, I think still it's a curable one. I think as we know, something like stage 3B, some cancers we can go for concurrent chemoradiation. Still, some of the cancers are curable. Even stage 4 people also, they are living longer for more than 5 years now. So with the advances in the management of lung cancer, with the so many pharma industries, they're trying to spend a lot of energy, time, and money in the research of this lung cancer. So, from a histology based chemotherapy from small cell lung cancer to non small cell lung cancer. In the non small cell lung cancer, we used to have the squamous, non squamous, the histology based therapy. Then I think we moved to something targeted chemotherapy like gefitinib, erlotinib, afatinib, dacomatinib, and ultimately this was imatinib. Next one is ALK positive, RAS positive. So many things happening over a period of this okay, decade, something now, MET amplification, HER2 amplification, immunotherapy, brilliant expression. So many drugs are available at this point of time. I think we should tailor the therapy based on the patient's needs and patients to maintain a good quality of life. Ultimately, they are living longer. So with this, so intention, I think there's AstraZeneca, they wanted to organize this conference or something webinar involving all the specialists who are very good in the management. They have contributed many things at the same. If we have a galaxy of experienced faculty in terms of management of lung cancer. Now, the first one, I think I would like to invite Dr. Rajni Priya. She's a well-known medical oncologist in Mahatma Gandhi Cancer Institute, Vizag. So, over to you, Dr. Rajni. I think you can go take us through your first presentation, like evolutionary milestones in non-small cell lung cancer management. Over to you, Dr. Rajni.
So thank you, sir. Thank you for the introduction. Can someone share the slides, please? Sir, am I audible, sir?
Yes, ma'am, you are audible. Just one moment. We are sharing the slide.
So, today I'll be talking on evolution of EGFR TKIs in treatment of patients with EGFR mutant advanced non-small cell lung cancer. Next slide. So this is the outline of the talk. We will be discussing about the EGFR receptor signal, Next slide, please. So EGFR signaling drives multiple biological leading to cancer, which makes it hard for treatment. The EGFR gene is a transmembrane tyrosine kinase receptor, which is expressed in epithelial, mesenchymal, and neurogenic tissues. So the activation of downstream pathway is involved in processes. So mutations in EGFR are common drivers in number of malignancies like pancreatic cancers, glioblastomas, and lung cancers. So EGFR, we have many targets available for EGFR receptors. Next slide. Next slide, please. So if you can see in the illustration, the aim of the epidermal duct with the epidermal growth factor receptor leads to the activation of the downstream pathway involving cell proliferation, cell survival. Whereas in EGFR mutated cases, irrespective of the binding of the epidermal growth factor with the epidermal growth factor receptor, those receptors are constitutively active, leading to uncontrolled cell proliferation and cell survival. Next slide. So these EGFR mutations can be either deletions, insertions, or point mutations. And these mutations are commonly found in the ATP binding region of the EGFR receptor, predominantly in the phosphate binding loop or the alpha C helix and the activation loop. So the common mutations which we see are at exon 18 through 21. So of which the most common mutations are the exon 19 deletions and exon 21 mutations, that is the L858R mutation, which are commonly seen. The other uncommon mutations are in exon 18, in exon 21 L861Q, and T790M mutation.
Dr. Rajni ma'am, I think your network has some issue.
Hello?
Yeah, ma'am, your voice is not coming. Some network, please come to the network.
Yeah.
Hello.
Am I audible now?
Yeah, ma'am.
Hello? Yeah. Yeah. Next slide, please. So in India, the EGFR positivity rate is around 25 to 30%. So we have already discussed the common mutations, which include the exon 19 deletions and L858R mutations. Next slide, please. So we know that these EGFR sensitizing mutations, we have a wide variety of drugs starting from the first generation TKIs, erlotinib and gefnib. Second generation TKIs, we have the afatinib and the dacomtinib, and the third generation TKIs like the osimertinib and the lazertinib. So for the uncommon mutations, we have robust data coming from the afatinib, and osimertinib can also be considered in these uncommon mutations. Whereas for the resistant mutations like the T790M, osimertinib and lazertinib, which are the third, are very active. Next slide, please. And in exon 20 insertions, they are usually resistant mutations and are usually treated with a platinum-based chemotherapy with or without amivantamab, which is a bispecific EGFR med. So this is a treatment line of the EGFR mutant non-small cell lung cancer TKS treatment, where multiple generation of EGFR TKS have evolved, starting in 2009, where the first EGFR TKI, that is gefnib, was approved for management in first line of this advanced non-small cell lung cancer patients. And after that, we have erlotinib, we have afatinib making their way. And in 2015, it was osimertinib, which was first tried in the second line management of these EGFR mutant non-small cell lung cancer patients who progressed on these first or second generation patients and have T790M mutation. Next slide, please. So it was a landmark IPASS trial, which has, it is a landmark trial in 2009, where the first generation TK, that is Gefnic, has shown to have improved PFS benefit over chemotherapy. So, next slide. So we have other trials where first generation TKs, all of them have shown to have PFS benefit compared to chemotherapy. And Lux lung trials where afatinib have shown to have PFS benefit compared to chemotherapy. And even the third generation TKs like the osimertinib, which was first second line setting, that is in the ORA trial, was in 2013, and later it has come to the first line treatment where it was compared head to head with the first generation TKIs, and it have shown to have PFS benefit initially in 2017, and recently we have even the OS data available also for the FLORA, where it is approved in the first line treatment in management of these advanced non-small cell lung cancer patients. Next slide. So the difference between the various EGFR TKIs, if you can see, the first generation TKIs, EGFR, Gefnic, and the erlotinib, they have a reversible binding, and usually they have less blood-brain barrier penetration. Coming to the second generation TKI, they have irreversible binding and they have very minimal blood-brain barrier penetration. Coming to the third generation TKIs, osimertinib and lazertinib, they have irreversible binding and they have significant blood-brain barrier penetration. Next slide. And coming to the T790M inhibition, it is osimertinib, which has shown to have activity against these resistant mutations. Compared to the first generation TKS, third generation TKS score well in their safety profile. This is because osimertinib binds only to the mutant forms of the EGFR, whereas the first and second generation have inhibition of also the wild types of EGFR, especially on the normal tissues, leading to side effects like rash, diarrhea, and meningitis. Next slide. Next slide. So these are the various studies with the first and the second first generation TKIs, that is IPASS trial with the Geftinib, the Uratac optimal show trial with the erlotinib, where you can see the median PFS is around 9 to 11 months as compared to chemotherapy, which is just 4 to 6 months. But there is no overall survival in any of the trial because of a crossover. Next slide. Next. So this is these are the Lux lung trials. Where in Lux lung 3 and 6, it has been compared with the chemotherapy, even it was only the PFS benefit. When compared, it was a PFS benefit, there was no overall survival benefit as well. Whereas in the FLORA trial, there was even overall survival benefit. So this is the only trial where add-on head comparison with the first generation TK, there is overall survival benefit. Even in the Lux lung trial, where afatinib was compared with the first generation TK, there was only the PFS benefit, but there was no overall survival benefit. Next slide. So these are the various PFS benefits of TKs, ranging from 9.5 months with the first generation TKs to as high as 18.9 months with the osimertinib. Next slide, please. So these are the various drugs which are approved in management of these EGFR mutated advanced non-small cell lung cancer patients. So the doses for the Geftinib is 250 mg OD, erlotinib is 150 mg OD, for afatinib it's 40 mg, and dacotinib it's 45 mg, and for osimertinib is 80 mg. Lazertinib, which is approved now in the management of these EGFR mutated first-line patient with amivantamab, but it's not available in India. Next slide. So from next slide, please. So all this first and second generation TKIs are approved in the first line management of these patients. Osimertinib is approved in the first line management of these patients alone or with chemotherapy. And in patients who have been earlier treated with the first generation TKIs, if they have T790M mutations, osimertinib is also approved in the second line. So as of now, In 2025, the management of a driver EGFR mutated advanced non-small cell lung cancer patient is if they have sensitizing mutations, like exon 19 and 85 beta, we treat them with osimertinib with chemotherapy. Or lazertinib with amivantamab. In future, if we have the lazertinib available, as of now, we are treating with osimertinib with chemotherapy or osimertinib alone, especially in elderly frail patients who cannot tolerate chemotherapy, and this burden is not very high, especially those don't have brain mets. So for patients who are not affordable for osimertinib, we can go with either first generation TKs, the geftinib with TK alone. For patients with common mutations, afatinib has good data and can be tried. So in patients with exon 20 insertion, we usually go with platinum-based chemotherapy alone with or without amivantamab. Last slide. Last slide, please. So finally, to conclude, these EGFR mutations, we have drugs with good experience with the first generation and the second generation DKs, and but osimertinib is known to have a good safety profile with a good blood-brain barrier penetration and is a standard of care either alone or in combination with the chemotherapy in management of these. These are only drugs which are shown to have both PFS benefit and overall survival benefit as well. Thank you.
Yeah, thank you, Rajani, for I think a wonderful exposition. Only problem is some auditory issues. So some people they could not
Yes,
hear.
sir. I'm traveling, sir,
Yeah.
actually. So
Yeah.
there's
Yeah, no
signal.
problem. But
Sorry, sir.
ultimately,
Sorry for
I
that.
think, yeah. Ultimately, there's a one, I think what you mentioned is the issue of blocking agents like from geftinib to osimertinib. All of us, we know that the geftinib and erlotinib were invented before the EGFR mutation detection. So we used to give these drugs for the poor performance status patients. So if they can't tolerate any chemotherapy, that was the initial management we used to do. Later, we realized that some people they responded very well with therapy. So EGFR mutation was the driving mutation, which can be blocked by these TKIs. So later, I think geftinib, erlotinib, and other afatinib, all these drugs, even though we got the good response systemically, but CNS penetration was very poor. So osimertinib again entered into the picture. So it changed the treatment management, I think, differently. Again, ultimately, the CNS metastasis can be treated, can be prevented. Ultimately, we are able to at least salvage some of the patients. The median PFS is around 1.5 years now, and the survival is around up to 3 to 4 years. So ultimately, we are able to treat many patients with recent generation TKIs with good quality of life. So that I think what you wanted to drive that one, I think you're driven very nicely. Okay, thank you very much. Again, in the panel discussion, we can ask some of the questions. Again, I'll request Dr. Next speaker, Dr. Paramjot sir. So he's the professor at the Department of Pulmonology in Nizam Institute of Medical Sciences. So sir was always more academic. Always he wanted to learn many things. We had many interactive sessions with him in the advances over a period of something 15-20 years. And ultimately, our goal is tissue is the issue. If you don't get the sufficient tissue for this, all the molecular analysis or molecular oncology test, so we don't give the target therapy. So sir is very good in something EBUS. So and also he's going to speak on something like what is the tissue is the issue, what is the importance of that one, and how do we do, and ultimately how can we assure the quality of tissue sampling. And thank you, sir, and over to you now, sir.
Thank you, Dr. Sadashivudu, for having me here. Am I audible? Am I audible? Hello?
Yes, sir, you're audible, sir.
Yes,
Yeah,
sir,
so
sir. You are audible, sir.
for having me on this Onco Voyage. And Can I have my slides, please? Can I have my slides?
Yes, sir.
The host, shall I press? Okay. Yeah. So my talk is about the role of EBUS in non-small cell lung cancer diagnosis and staging. Next slide, please. Yeah. So non-small cell lung cancer accounts for majority of the lung cancer cases, and accurate diagnosis and precise staging are very important for the treatment and predicting prognosis. Now, once you have a endobronchial lesion, you can get a tissue, as Dr. Sadashivudu was saying. Tissue is the issue. If the lesion is in within the airways, and you can get the tissue using a fiber optic bronchoscope. But what if the lesion is outside the airways, or where it's peripherally located, a small nodule, like 1 centimeter nodule? How do we access this? That is where EBUS comes. EBUS has an established role in diagnosis and staging of non-small cell lung cancer. And EBUS TBNA, with or without endoscopic ultrasound FNA, is the preferred first step procedure for sampling centrally located tumors and mediastinal lymph node metastasis. Next slide, please. So what is EBUS? EBUS is endobronchial ultrasound, which is a minimally invasive bronchoscopic technique that utilizes ultrasound to visualize the structures adjacent to the airways. We have two types, the linear probe and the radial probe. Next slide, please. So to your left is the linear probe, where we can visualize the structures adjacent to the proximal airways, and after visualizing with an ultrasound probe, you can actually see the characteristic of the lesion, study them, measure the size, and then a needle goes there. Depending on the size, the length is decided. We go there and sample the tissue. So the linear EBUS is used to sample lymph nodes or masses that are abutting the tracheobronchial wall. And to your right is the radial probe. And this is the probe which is used to access the parenchymal lesions. So as small as, say, the 1 centimeter pulmonary nodule can be accessed. And of course, with advancement in techniques, as small as 8 millimeter pulmonary nodules are also being sampled. So the radial probe is for sampling the parenchymal lesions, because it gives a 360-degree ultrasound waves, and it captures the parenchymal lung lesions. So convex or linear probe is for sampling the lymph nodes or masses abutting the tracheobronchial wall. The radial probe is to sample the parenchymal nodule. Next slide, please. So these are some of the differences. So we have already, I think we have discussed some of them. And in linear probe, we have this facility of Doppler, where you can differentiate a vessel from the mass or a lymph node, which is not there with the radial probe. And linear probe, we can sample the tissue in real time, whereas in ultrasound, it's not possible. So I'll come to the technique later. Next slide, please. So understanding of the lymph node stations and the vascular structures, understanding the mediastinal structures is very important for a person who is going to sample the mediastinal nodes or the masses. So we have some, I think all of you know, we have a supraclavicular area. Some nodes are there, and the superior mediastinal nodes from 2R to 3A, 3 posteriorly we can't sample it. It's not visible, and sometimes we can. I mean, it's possible posteriorly also. Mm, 4R, 4L, again lower paratracheal, and then you have aortic nodes like subaortic and paraortic lymph nodes, subcarinal, paraesophageal, pulmonary ligament, hilar, interlobal, lobal. These are the lymph node stations that we have to have very good knowledge about the anatomy, as well as not only lymph nodes, even the vascular structures. Anatomy is very important. That's how we recognize the stations. Next slide, please. Now, if you see this slide, the green dot, total green dots are the ones which can be accessed through the eBus. That is the 1, 2, 2R, 2L, and hilar, interlobar, lobar are the are the group of stations of lymph node which can be accessed only through eBus. Whereas the lower paratracheal, subcarinal, and subbiotic, 4, 7, and 5, they can be accessed both through eBus and EUS. Whereas the paraesophageal 8 and pulmonary ligament station 9 can be accessed only through endoscopic ultrasound guided FNAC. So some people use the same EBUS also as to sample, go into the esophagus and sample these lymph nodes, but we don't do it. That's not our area, so we don't have expertise in getting into the foot pipe. So we only go into the airways, sample the whatever lymph node that we can sample and come out. So we can sample these lymph nodes through EBUS or through EUS also. Next slide, please. So these are some of the lymph node characteristics that we initially study. Once we see a lymph node, we separate it from vessel. The size, the shape, the echo texture. Using using the M mode, we visualize this, appreciate these characteristics. The echo texture, the hilar structures, and coagulation necrosis. And there are other modes with using a Doppler, we can see the vascularity. If we have an elastographic technique, we can know the elasticity of the mass or the lymph node. Next slide, please. So these are the MOD images. So first thing is, my cursor, if you look at the second, first thing we appreciate is the size in the short axis. Second is the shape, is it round or oval? Third is are the central hilar structures visible or not? How are the margins? Are they distinct or indistinct? How is the echogenicity of the node or the mass? Is it homogeneous or a heterogeneous? Is coagulation necrosis present or not? Are there calcifications and the vascular pattern using the Doppler? So these are some of the images that we appreciate before actually sampling the lesion. Next slide, please. So using these images, it's possible to make an intelligent guess whether the lymph node or mass is malignant or benign. If the size is bigger the size, greater the probability of it being a malignant. Round shape is malignant as compared to an oval shape. If the margins are distinct, it is malignant as compared to indistinct, which is seen in a benign lesion. If the ecotexture is heterogeneous, it is malignant. If the central hilar structures are absent, then it is a malignant lesion. And if there is a coagulation necrosis present, it is usually malignant, but it can also be present sometimes in tuberculous lymph nodes also. And using Doppler, if the lesion is vascular, probability of it being malignancy is high. Then if we have an elastographic mode, if you see this blue color, then it is elastic tissue. This also will help us to take sample from this area if we have this elastographic mode. So based on all these features, we can make an intelligent guess whether we are dealing with a malignant lesion or a benign lesion, and site of taking a biopsy also will be helpful with these images. Next slide, please. So with the radial probe, the normal lung will be like a snowstorm appearance. The central round one is the radial probe inside the airway, and around that is the aerated lung, which appears like a snowstorm appearance. And if the surrounding lung has a ground glassing, then this is a blizzard pattern. So if you can have a adenocarcinoma with having a ground glass appearance also. So if we have a ground glass appearance on CT and on radial EVAs, the image is like blizzard pattern. If you have a nodule, it is hypodense lesion adjacent to the probe. The white line that you see is the normal aerated lung. The hypotense lesion is the mass lesion. The mass lesion is eccentrically located to the probe, and here the mass is concentrically surrounding the radial probe. So you could have a concentric lesion, eccentric lesion using an radial EBUS probe. Next slide, please. So how do we do it? The linear EBUS is usually done under moderate sedation or general anesthesia. Usually we take the help of our anesthesia colleagues. So we are doing it under general anesthesia, and the scope is passed orally. And once we visualize the mediastinal structures, and then we appreciate all the characteristics that I have already mentioned, and use the Doppler to whether to differentiate it from the vessel. So once the vessel is out, when we concentrate on the abnormal structure, usually a mass or a lymph node, then a needle is passed under vision, usually 21 gauge, but these days 21 is not available. So 22 gauge is also okay. So 21 gauge is passed through the working channel, and the needle is advanced to the node under real time, and several passes are made. 3 to 5 passes are made before we take a cytological material. Sometimes we get a core also, so that core also will be, and then the processing and the making of the slides, the assistant will take. And if we have a pathologist with us, a rapid onset examination is also made. Next slide, please. So rapid onset and post procedure. Usually, it's a very safe procedure. Minor bleeding or transient cough may occur, but and sometimes hypoxia does happen, especially in a COPD patient. CO2 retention also can happen, but usually these are very minor and rare. Next slide. So radial EBUS is also more or less the same because this is we use the ultra thin flexible bronchoscope. It can be done under local anesthesia with conscious sedation, or sometimes if the patient is a little sick, we do it under general anesthesia, where an ultra thin bronchoscope is passed through either nose or mouth, and then through this working channel, the radio probe is passed, and then this radial probe, before passing, we have to have a sheath, and through the sheath radial probe is passed, and then we visualize the lesion, locate the lesion, and once having located the lesion, we remove the radial probe, we allow the sheath to stay in that location itself, and then next slide please, pass the accessories. Yeah, we pass the accessories, and whether the accessories are in the lesion or not will be checked by either fluoroscopy or CM. We have CM with us, so we check with CM whether the whatever is the tool, whether the forceps or needle or a brush, whatever is the tool, whether it is there in the lesion or not, will be checked in the CM, and then we sample the lesion, and typically, it takes about 20-30 minutes for the procedure to be completed. And sorry, and this is a daycare procedure. Usually, the patient goes home the same evening. So once they are fully, if they are under general, if the procedure is under general anesthesia, we make sure that he is out of anesthesia, and then we send the patient home. Next slide, please. So linear EBUS, as I said, it is best for tissue diagnosis and molecular testing from lymph nodes or centrally located tumors that are just outside the airways. Then radial EBUS is for peripheral lung nodules, and here also we can get adequate tissue for whatever the molecular diagnostic tests or PD-L1 assessment is required. That with a very high degree of sensitivity and specificity in diagnosing non-small cell lung cancer. Next slide, please. So how do we increase the yield in EBUS? Because this is an expensive procedure done under anesthesia many times. So ROSE is one such technique where we ask the pathology people to be by the side of us. Whatever material we take, we give to them, and they see the slide and say whether the tissue is adequate or not. Once they are satisfied, we stop there. And as I said, needle size does matter. 21 gauge gives a better yield. Cryobiopsy also gives much better as compared to the needles, and we have this cryobiopsy also with us. Fluoroscopy or CM again will improve in having a better yield. Electromagnetic navigation bronchoscopy is another imaging tool which will help us to uh, go into the proper segment or subsegment wherever we do not have electromagnetic navigation, but we have lung point. I will show you the images. So lung point will, it's like a GPS. It will tell us in which direction we have to go, in which segment we have to go. Cone beam CT, this is again an advanced imaging tool, and robotic bronchoscopies. These are very, very expensive, not available routinely. Robotic is not available in India. Cone beam CT, some centers do have. NIMS also has cone beam CT, but it is with intervention radiology people. We don't have in our bronchoscopy suite. So these are all the different ways to increase the yield. Next slide, please. So next, mediastinal stage is crucial aspect. The crucial aspect is the staging in the lung cancer. Next slide. It's not coming. Yeah. So whether the possible for staging is important, whether patient is a surgical candidate or not a surgical candidate. I mean, whether patient is suitable for surgery or not. So that proper mm, decisions can be taken whether should be managed surgically or medically. Next slide. Yeah, this is also obviously it will help us in staging also. So the main role in staging with EBUS is to determine the end component of TNM staging. The mediastinal hilar, the upper paratracheal, lower paratracheal, and all those hilar and subcarinal lymph node, lobar, interlobal, all those lymph nodes can be sampled. Uh, and then usually we sample the highest node. I mean, the contralator. We go into the contralateral side first. If that is positive, then we stop the procedure because we have already upstaged there. So for upstaging and downstaging, we see the first the highest node and then go down. And EBUS TBNA allows real-time sampling. I have already told you, and clearly the EBUS scores over mediastinoscopy because it is minimally invasive. It accesses more nodal stations and there is high sensitivity and diagnostic hit. Next slide, please. So in all potentially resectable lung carcinomas, staging should be done irrespective of presence or absence of abnormal mediastinum, either on CT scan or PET scan. Say, for example, if the mediastinum is abnormal, I mean, there is something abnormal in the mediastinum. In a proven case of lung cancer, the abnormality could be a granulomatous disease, infection, or non-infectious inflammatory conditions. If you have a malignant lesions which are abnormal, then you can downstage it. On the contrary, when the mediastinum looks very normal on CT or PET scan, it could be false normal. Here also, EBUS has to be done. See whether there are any lymph nodes which we did not pick up on PET scan, and if the nodes are positive, then upstaging is done so that unnecessary surgeries are prevented. Next slide, please. So there are some contraindications, absolute contraindications, obviously lack of consent and severe bleeding diathesis or cardiac arrhythmias, recent MI, or if there are benign or malignant lesions of the upper airways where a scope cannot be passed, where you cannot do it, and we can take the help of ultrasound if those are accessible through ultrasound. And there are some relative contraindications, not so really important. Next slide. So common complication is transient hypoxia, and all other complications are extremely rare. Even in our practice, these are very extremely rare. Next. So this is one example that we have had. This is a case of invasive ductal carcinoma of left breast lumpectomy done February 25, referred to us for bilateral detected lung nodules. So we have used a fiber radial EBUS, localized the lesion, and then the image that you are seeing, colored image that you are seeing top right and top left, and in the lower lower one to your right, you see a blue line. This is our lung point. This is like a GPS. What we do is the CT images are fed into this console of this lung point, and that will first detect the nodule, and it will give us the path to that nodule. So as you are passing your scope, this blue line will help you. It like a GPS. It will help us to pass our scope in that particular direction. Once we have reached the lesion, here under CM, we pass the tool, whatever tool that is required, we pass, see that the tool is inside the lesion, take the appropriate specimen and come out. So this turned out to be a necrotizing granulomatous inflammation. The common nodules we see even in malignancy is a granulomatous infection in our setup. Usually it is tuberculosis. This is a very common granulomatous condition. So every nodule, even in the setting of malignancy, is not metastasis. It could be infection, which needs proper sampling, and so that will help in appropriate treatment. Next slide. So this is our setup in our institute. Thank you very much for your patient listening. If there are any queries, I will answer.
Thank you very much, sir. I think wonderful exposition. I think really you enlightened us, because all of us will always talk about our oncology part, but I think this how a pulmonologist plays a major role. At the same time, what are their difficulties? I think you have clearly mentioned all the inputs. Really is a great talk, sir. Thank you very much for your valuable and informative lecture. And we will again have something like a panel discussion, sir. So at that time, I will ask any person has any of the doubts, and we can have the questions at that point of time. Now I would like to request Dr. Rakesh Pennanti to go ahead with this again, reinventing this adjuvant therapy, because the EGFR mutated patients, if the early stage cancer, once we do the surgery, we don't give any adjuvant therapy. So that was our concept. We did not. So, but nowadays, because of this immunotherapy, target therapies, we don't want to see any relapse and recurrence in the future, because the patients, once they come to us, the advanced stage. So to prevent that, again, recurrences, and either the local recurrence or systemic recurrence, we have some immunotherapeutic agent, target therapy, SPG agents. So especially EGFR mutation patients. I'd like to request Dr. Rakesh Pennanti. Is a consultant medical oncologist in Basatarakam Hospital. So he's going to deliver the lecture on this again, reinventing adjuvant therapy. Over to you, Dr. Rakesh.
So good evening, sir. Thank you for this opportunity. Thank you, AstraZeneca, for this platform. And I think most of the slides have been provided by AstraZeneca itself. So as sir was discussing, this is to reinvent adjuvant therapy in EGFR mutation non-small cell lung cancers, especially the early stage ones. We have already had an elaborate discussion, which was done by Dr. Rajni Priya on the advanced stage NSCLC. We are going to discuss the utility of the TKI therapy, especially the osimertinib, in the early stage EGFR mutated non-small cell lung cancer. So I think the outcomes of survival in resectable non-small cell lung cancer are need to be improved, as we know that lung cancer really contributes to nearly 30% of all cancer-related deaths. So any improvement in lung cancer outcomes definitely has a long way to show the improvements in the overall cancer outcomes as well. As of now, the statistics are very clear. We are looking at non-small cell lung cancer as a significant histology in the lung cancer per se. They contribute nearly to about 80 to 85% of all lung cancer histologies, and about 1/3 of the cancers who are diagnosed are in the resectable stage. Again, the 5-year overall survival depends upon the stage of the diagnosis, even in the early stage, even in resectable cancers. Obviously, the stage 1B cancers have a much more better survival at about 75% compared to that of the stage 3A, which is about 30 to 45%. So coming to the EGFR mutations, this is the most common oncogenic driver mutations in non-small cell lung cancer. And based upon the population that we are studying, either it could be Caucasian or East Asian or Central Asia or Southeast Asia as we are in, it depends upon the location of the patient. And basically, the least proportion is seen in the Caucasian population, which could be as low as 10 to 25%. The highest proportion is seen in the East Asian population, which could be as high as 50%. Among the published data from the Indian populations, it looks like we are between the Caucasians as well as East Asians, about 30 to 45%. And coming to the outcomes of early stage EGFR mutation non-small cell lung cancers, unfortunately, these patients don't respond as well as to immunotherapy that are being standard of care in the non-driver mutation non-small cell lung cancer. The utility of immunotherapy, both in the adjuvant phase as well as post-CTRT as a maintenance phase, we can see that the EGFR mutated non-small cell lung cancers don't do as well as the counterparts without those mutations. So this is an unmet medical need to improve the outcomes of these patients. We can see that nearly about 5-year survival is about 40 to 45% for these patients. And let's see how the osimertinib or the utility of TK therapy in the adjuvant setting has improved the outcomes. So these are the testing recommendations for early stage non-small cell lung cancer. And these recommendations are always dynamic, and it's a living document that keeps on changing over a period of time based upon the evidence that is out there. So for a non-small cell lung cancer, as of now in 2025, we are at least looking at 3 biomarkers.
ఏదో గిఫ్ట్ ఇచ్చారా టాక్ ఇచ్చాను అక్కడ ఇచ్చారు నాకు తెలియదు.
So EGFR mutation testing as well as the ALK testing and PD-L1 testing. All the 3 are recommended as of now in 2025 for those patients who are having resectable non-small cell lung cancers. So this is the current testing and treatment patterns. This is presented as an abstract in ASCO 2023, and we are looking at the real-world evidences that is gathered between March 2021 and October 2022 across 3 different setups: Middle East, Africa, Latin America, and Asia. And we can see the proportion of patients with the EGFR mutations is about 51%. And even among them, the most common mutation is the usual suspects of deletion 19, as well as the L858 substitutions. So most of the early stage histological and mutation profile usually matches the advanced stage as well. So this is the current treatment patterns. As we can see across the different stages, unfortunately, only about 2/3 of the patients, only about 1/3 of the patients are able to take systemic therapy, and the rest of the 2/3 of patients are limited to only surgery alone. As we can see clearly from stage 1B to stage 2B, where the outcomes with surgery alone, along with systemic therapy, are better. Even in that setup, also we are looking at only about 22.5, 38.2, and 33.7. And on average, about 1/3 of the patients are able to take the systemic therapy, and the rest of the patients are unable to take the systemic therapy and were limited to only surgery. And that could be one of the reasons of high recurrence rates. So we can see about 50 to 60% recurrence rate at around 5 years. So it is an unmet medical need, and we need to improve the uptake of systemic therapy by providing better neoadjuvant and adjuvant protocols. And we also want to see how TK therapy can improve the outcomes, whether the improving the DFS or improving the overall survival, at the same time preserving the quality of life. So this is the basically the pivotal trial or landmark trial that have suggested the utility of systemic therapy to improve outcomes in operable non-small cell lung cancers. It is done basically to show the overall survival benefit. As you can see, the DFS and overall survival benefit about 5% at the end of 5 years. And this has actually changed the practice of utilizing the platinum-based combination chemotherapy for most patients with resectable lung cancer after surgery. What about TKI therapy? I think there are several trials that have tested the previous generation TKIs, which is erlotinib and geftinib. And we can see what is the consistent outcomes of all these clinical trials is that there was clinically meaningful improvement in the DFS. However, this does not translate into overall survival benefit. As we can see, this Chinese trial, there was significant improvement in DFS, nearly 10 months addition to the absolute numbers. However, there was no significant improvement in the overall survival. So when we have a hint of benefit, but that doesn't translate to the overall survival, we'll always fall back on meta-analysis. This was a meta-analysis of 6 randomized trials, including individual patient data of nearly 2,000 patients, about 600 with each of a mutation positive. And clearly you can see that there was a significant improvement in the DFS. As you can see, the hazard ratio 0.52, suggesting a 45% reduction in the risk of disease recurrence. However, this did not translate into overall survival. Hazard ratio 0.64. And even this 0.52 DFS, it is subject to whether you are giving chemotherapy in addition to TK therapy or TK therapy alone. As we can see, adjuvant TKI versus chemotherapy, it was 57% compared to adjuvant TKI after chemotherapy, it was about 38%. So there is a lot of ambiguity of these clinical trials, and this data has not resulted in any change in clinical practice. The front generation or earlier generation TKI of the geftinib and erlotinib has not been utilized as a standard maintenance treatment or adjuvant treatment because it is limited by several trials with heterogeneous outcomes, and more importantly, there is no overall survival benefit. So in general, what we are looking at is with the front generation TKI therapy, we are delaying the recurrences, but we are ultimately not able to prevent the recurrences. So where comes the ADAURA trial? This is a utility of osimertinib as adjuvant therapy. This is included all the resectable cancer patients, whether the patients have taken with or without adjuvant chemotherapy are included in this clinical trial. And stratification factors are stage 1B versus 2 versus 3A, and type of mutations, and race, basically Asian versus non-Asian. And patients were randomized to osimertinib 80 mg once daily or placebo, and treatment was planned for 3 years. The primary endpoint of this trial was DFS by investigator assessment in stage 2 and stage 3. And key secondary endpoints are all overall population DFS and again overall survival as well. So this is the ADAURA trial primary endpoints of DFS. As we can see, significantly improved DFS across the primary population as well as the overall population. As we can see, hazard ratio 0.23, which is statistically significant, both in the stage 2, stage 3 population as well as in the overall population. And there is not much of a drop in hazard ratio, 0.23 in the stage 2 and stage 3A, and in the overall population it is about 0.27. Coming to the other important points, it has significantly improved the CNS DFS as well. You can see the hazard ratio of 0.24. Again, we can see that the median CNS DFS has not reached in both the cohorts, but we can clearly see from the Kaplan curves that there is a drop from very initially from nearly 3 months to 6 months point of view in the placebo arm, suggesting that there is a consistent increase in the CNS recurrence rates post completion of adjuvant therapy. And we need a drug that has a good CNS penetration and also a good CNS DFS improvement to actually get an overall survival benefit. So this is the patient characteristics of overall population. As we can see, the adjuvant therapy was utilized in about 60% of the patients, and nearly 40% of patients have not taken adjuvant therapy. This is closely resembling the usual clinical practice, where most of the patients, a significant majority of the patients, either delay this adjuvant treatment or altogether don't take the adjuvant treatment because of multitude of factors, both medical and non-medical. So this is the overall survival outcomes from stage 2 and stage 3A. I think again, we can see a significant improvement in the overall survival with an absolute benefit of 12% at 5 years, hazard ratio of 0.49, which was again overwhelmingly in favor of osimertinib utility. Again, if you look at the overall population as well, we can see clear improvement in the outcomes. The absolute benefit stays true at around 10% at 5 years, and hazard ratio 0.49, again statistically significant. This is by stage. Again, these numbers are not very statistically powered to show the difference, but we can see the message here. There is a consistent improvement in the hazard ratios towards this. Most of them are towards statistical significance as well. Against stage 3A 0.37, which is again statistically significant. So the message is that the overall survival benefit with the utility of osimertinib in the adjuvant phase show consistent survival benefit across the different disease stages. So this is again with respect to whether the patient has taken adjuvant therapy or not, or whether the patient has deletion 19 or substitution in the L858R. Survival benefit was consistent irrespective of the type of mutation and irrespective of whether the patient has taken the chemotherapy. So coming to the subsequent treatment, we can see about again, subsequent treatment was TK therapy in significant majority of these patients. About 76% of the patients have taken subsequent TK therapy in osimertinib group compared to 88% in the placebo group. For obvious reasons, chemotherapy and radiotherapy and subsequent anti-cancer treatment was not a hurdle for the patients who have taken osimertinib. Most of the patients have very good quality of life despite taking osimertinib. So again, the safety analysis, which is most important, you can see that grade 3 toxicities was about 11% in the osimertinib group, and this fortunately did not result in any deaths. And serious adverse effects are seen in about 3% of patients. So the key takeaway from this overall experience is that we need to improve the survival for our EGFR mutation non-small cell lung cancer patients. We need to identify these mutations very early prior to surgery itself. So we do not have to miss on the opportunity of giving the TKI therapy because it might be a situation in which patients are reluctant to take these drugs. So we need to have a good collaboration with multidisciplinary team so that we are properly staging these patients, having the adequate tissue material in hand to get the ancillary testing of at least EGFR, PDL1, and as well as ALT testing prior to surgery so that we can plan the adjuvant therapy well in advance. Again, so patients may ask for treatment options which are best for survival probability, and we need to discuss the opportunities beyond chemotherapy, and ADAURA trial has clearly given us the plausible data that there is an improvement in the overall survival in eligible patients with EGFR mutations post-surgery. And this benefit is irrespective of whether the patient has a exon 19 deletion, L858 substitution, or whether the patient is fit for chemotherapy or not. With that, I would like to thank, and I would be open for any questions. Thank you very much.
Yeah, thank you, Dr. Rakesh. I think wonderful exposition. Again, you have mentioned this adjuvant therapy definitely will prevent these recurrences. The only problem is, as you have mentioned, sometimes the oral survival may not be that beneficial because we are able to salvage those patients with again advanced therapies. Maybe there's a reason, but ultimately we can prevent the recurrences, local recurrences, especially CNS recurrences. What you have mentioned just now, CNS is a major issue in the lung cancer, so definitely we can prevent those things also. So we'll have again the panel discussion next, and then we can discuss that one. Now I would like to request Dr. Shikhar Kumar. Now Shikhar again is a well-known medical oncologist. Now he's going to talk us in transforming the unresectable stage 3. So resectable, like Rakesh mentioned, resectable and adjuvant therapy. Now the Shikhar Kumar is going to talk about the stage 3 is a non-small cell lung cancer. Again, as I mentioned, stage 3, again, we have the A, B, C, whether it can go for surgery or concurrent chemoradiation. And he's going to take us through from Pacific to Lara, the clinical trials. Over to Dr. Shikhar.
Thank you, Sadashivudu sir. Thank you, AstraZeneca, for having me here on this wonderful platform. Please allow me to share my screen. Can I share my screen, please? Please give me the permission.
Yes, sir.
Right. So we already had excellent talks before this, looking at how EGFR mutations have changed the way we approach the treatment of lung cancer. We will now move to the stage 3 setting, which is beyond the realm of curative intent surgery in many cases, and we'll see how even there, how landmark phase 3 trials have changed the treatment outcomes and the survival outcomes. So stage 3, what you need to know is essentially that it is not one disease. Stage 3 is again a very heterogeneous group of patients because as you can see, this is a mixture of 3 different substages, stage 3A, 3B and 3C as per AJCC 8th edition. So 3C was introduced in the 8th edition, which was not there in the 7th edition. This was exclusively patients who had contralateral mediastinal node involvement with N3 disease with T3, T4 primaries. And 3A, 3B, as we all know, is subdivided on the basis of the amount of the number of stations that of the mediastinal node involvement, and they differ in terms of how we approach them as far as the management is concerned. So why 3C was created in the 8th edition is, as you can see, that the overall survival for 3C is even poorer, mirroring the survival outcomes for stage 4 non-small cell lung cancers, and that is why a separate stage was created. Within 3A and 3B also, as you can see, it is a very heterogeneous group, which can include both N1 station involvement or N2 station involvement. Both are lumped into 3A. And 3B is when you have multi-station N2 involvement with T3 or T4 primaries. So as you can see, it's a very heterogeneous subgroup. These patients should always ideally be discussed in a MDT setting, in where you make the surgical plan very clear upfront, that whether it's upfront operable or whether it's going to be operable after neoadjuvant treatment, or whether the patient is frankly inoperable disease. So as I said, these patients require MDT assessment. Multiple things have to be taken into consideration, not only the disease extension, but also the patient's performance status, age, comorbidities, what is the underlying lung function. Say, for example, if the patient has a bad COPD, then the patient is not fit for surgery. And then we have to look for non-surgical treatments and so on and so forth. And then you have to look at the tumor factors, whether it's a multi-station N2 disease or it's a single station N2 disease. Can radiation therapy be delivered in a single safe portal or not? And there are many other factors which need to be taken into account before planning the treatment. So for stage 3 unresectable disease, we already saw this guideline being shown by Rakesh sir, in which we have to test them all for PDL1 testing, and EGFR mutation analysis has to be done. This is as per the practice changing data from the LAURA trial. And now, as per the recently published, I think it was last year, the ALINA trial data came out with the adjuvant alectinib. So now you have to test for EGFR and ALK also in these patients, in addition to PDL1 and EGFR. So this is a busy slide. What this basically shows is what we do as of today. That is, patients with stage 3 lung cancers who are not operable, who are planned for radical intent chemotherapy. We give them concurrent chemotherapy with either etoposide cisplatin or a more modern and a more convenient regimen of weekly paclitaxel and carboplatin. And this definitive CTRT is widely recommended as the standard approach for these patients who have unresectable stage 3 disease. What we also need to know is that radical intent CTRT, the patients need to be chosen carefully, because as you can see, the completion rate for this is not very high. It's only around 60 to 80% as per the literature. So patients who have a good performance status, and you know that the entire portal of the entire disease, including the primary and the lymph nodes, can be safely included in the portal. These are the patients who are planned for radical intent CTRT. Otherwise, patients who do not fit into this criteria are usually sometimes given induction chemotherapy, and after that, then they are assessed for eligibility for concurrent CTRT. So a lot of trials have been done to see whether patients can improve with any consolidation therapy post CTRT, and the main reason for this is because the outcomes post radical CTRT were quite modest, and left a lot of room for improvement. The median progression-free survival would not exceed more than 5 to 6 months, and the median overall survival in the older trials with radical CTRT was only around 15 to 20 months. So different trials have been done. This is the trials which have been done with consolidation chemotherapy. This was the Hoover oncology group trial, which looked at consolidation with docetaxel-based chemotherapy after patients completed etoposide cisplatin and thoracic CAR-T. As you can see, this was a negative trial, and it was negative for its OS endpoint. Another trial, the KCSG trial, looked at consolidation docetaxel cisplatin after completing the same chemo plus RT regimen in a concurrent fashion. Again, addition of the same chemo in a higher dose in a consolidation fashion did not improve the PFS or the OS. Similarly, two chemo regimens were compared head-to-head in combination with RT in the Proclaim trial, PEMSIS versus etoposide. Again, this trial was negative. Different strategies, dose escalation of RT was considered in this 2x2 factorial design trial, RTOG 0617. So one arm included escalation to 74 gray of radiation versus the standard 60 gray. Unfortunately, dose escalation to 74 gray again proved futile. The other arm of the 2x2 design of this trial looked at consolidating with the EGFR map, that is cetuximab. Again, this was also negative. Similarly, the earlier trial of consolidation with gefitinib, this was not in EGFR selected population, this was in all comers. So it was not of course, it's a historical trial, not relevant as of today. But again, this trial again did not show any improvement with the addition of consolidation gefitinib after completion of CTRT. So a lot of strategies have tried and failed to improve the outcomes post CTRT in the past. In this setting, the Pacific trial was designed. This was a modern trial which looked at stage 3 unresectable lung cancers who did not progress after completing platinum-based CTRT. That is important to note, that patients should not have progressed on this treatment. And what is also you need to know is that this trial took all comers. Of course, this is the older trial compared to the more modern trials. EGFR patients, EGFR mutated patients also were included in this trial. And after completing CTRT, when the reassessment was done and these patients had not progressed, they were randomized 2:1 to durvalumab maintenance for 1 year versus placebo. And they were stratified by age, sex, and smoking history, co-primary endpoints being PFS and OS. So in this setting, we all know the data which came out, the PFS was significant and the OS 5-year data also was significant. You can see that there was a significant improvement in 5-year survival from 29 months in the placebo arm to 47 months in the experimental arm. The 5-year OS, as you can see, also at 60 months, is a significant jump of almost around 10% in the experimental arm. The PFS also, and if you look at this subgroup analysis, what is I would draw your attention to the post hoc analysis in which the PDL1 less than 1% subgroup appeared that they did not benefit with this consolidation. But keep it in mind that this is a post hoc analysis. This is not a pre-planned analysis. And almost 1/3 of the patients in this trial, the PDL1 data was not known. So within the limitations of that, possibly patients who have PDL1 more than 1% or more than equal to 1% of the patients who would definitely benefit with the addition of consolidation durvalumab. Rest all subgroups, there was no clear subgroup which did not appear to benefit with the addition of consolidation durvalumab. This is the PFS data. Again, as you can see, the median PFS with only CTRT, very, very modest of around roughly 5 to 6 months only as expected. And this almost tripled to 16.9 months with the addition of 1 year of consolidation with durvalumab. Even at 5 years, as you can see, 1/3 of patients were maintaining a durable disease control, which is quite remarkable, considering that otherwise, without this, the 5-year PFS with only the placebo arm is only around 19%. PFS data also again mirrors the OS data as far as the subgroups are concerned. So what is also interesting to note is that the Pacific trials intentionally did not include the subgroup of patients who would have a high risk of radiation pneumonitis. So B20 less than 35% patients only were included. That is, patients who had a high lung exposure with radiation were excluded from the trial. So you can see even in the placebo arm, patients who had a radiation pneumonitis were around 25%. And this was marginally higher in the group of patients who received durvalumab consolidation. Fortunately, grade 3, grade 4 adverse events were very uncommon in the durvalumab arm. So moving on, if you look at the subgroup of patients who were included with EGFR mutation, which was a very small 5 to 6% subgroup in this trial, when this was analyzed post hoc, there was no clear-cut benefit with the addition of durvalumab maintenance. And it is because of this fact that the subsequent trial was designed, which was known as the LAURA trial. So the LAURA trial took stage 3 patients who had exclusively EGFR mutant, and that to the sensitizing EGFR mutations with exon 19 deletion and L858R mutation. Again, stage 3 disease, good performance status, and patients who had completed their chemoradiation. Again, 2:1 randomization between adjuvant osimertinib. And what is important to note is that this osimertinib duration was until progression. This was not for a defined period, unlike ADAURA, which was for 3 years, and other adjuvant trials would have a specified period. This was until progression. And the placebo arm was compared against osimertinib. So again, here the primary endpoint was not PFS and OS, it was only PFS, and the OS was the secondary endpoint in this trial. So again, the groups were well matched as expected. Majority of the patients had stage 3B disease. Some patients had stage 3C disease, around 17%. Most of them received concurrent CTRT, around 90%. And majority of them, by virtue of their EGFR mutation status, had adenocarcinoma, unlike LAURA trial, unlike Pacific trial, where almost half of them had squamous cell carcinoma. Here, the majority of patients were adenocarcinomas. So this is again, we know the data, very striking difference in the PFS. Again, very similar to the Pacific trial, median PFS with only CTRT, only around 5.6 months, exactly the same PFS achieved with CTRT. And you can see a stark difference, the median PFS of being 39 months in the adjuvant osimertinib. This is highly statistically significant. And if you look at the different subgroups, again, with such a wonderful forest plot, you can make out that almost every single subgroup is showing stark benefit with the addition of adjuvant osimertinib. So even the tumor responses, as we know, even in the metastatic setting, tumor responses with osimertinib tend to be very gratifying with almost 75 to 80% response rates. And that is what you are seeing here as well, that with the addition of osimertinib, the objective response rate also increased significantly, and the disease control rate also was close to 90%. So if you look at the sites of new lesions in patients who progressed, ultimately, as you can see, osimertinib is expected to have CNS protective effect. So you can see very few patients developed new brain lesions compared to patients in the placebo arm, and much fewer patients developed new lung and liver lesions as well compared to the placebo arm. So overall survival data is currently immature. The median OS is not reached in the placebo arm. It's around 54 months in the osimertinib arm. So this is the trial is still under follow-up, and we will get the long-term survival data subsequently. If you look at the safety and safety data, it is as expected. There was no unexpected side effects with osimertinib. Adverse effects leading to dose discontinuation of osimertinib were again only around 13%, which is almost similar to what you would see in other trials. And serious adverse events leading to death was again only 1%. So I think that is okay. I'll just wrap it up. So this is to conclude that in both the adjuvant set in the just a second. So to conclude with the durvalumab consolidation, you can see that this has become a standard of care. You have a durable PFS as well as OS benefit with addition of durvalumab consolidation. But patients with EGFR mutation, they do not benefit with this. And it is in that setting where the LAURA trial data is again practice changing with a stark improvement in both PFS and the OS data. Of course, because of crossover, the OS data has to be the OS data will obviously be affected because of the crossover. So, but the PFS is significantly superior, and this is the current standard of care in my mind. Thank you so much for your patient listening, and would be happy to take any questions and comments.
Yeah, thank you, Dr. Shikhar. I think wonderful exposition again. You have described very well in the management. Okay, so here is again what I mentioned is again the stage 3. A, B, C, something. We have so many different subtypes are there. So in this, I think you wonderfully explained this importance of division again. So Dr. Paramjit sir clearly mentioned. So PET positivity doesn't mean that it is a disease itself. So here, I think we'll go to the next session. That the session is again just whatever we have discussed till now. Just I wanted to have something, have a discussion. I don't want to go in depth of each and everything because already you have mentioned clearly. Can I have my presentation? Just I think otherwise you can make my other laptop as something like a panel, then I can share my presentation. So this is my iPhone. Can you share the presentation? Otherwise, I'll share my presentation from my end. Shikhar, I think you can unshare your this one. No? So you can stop sharing your. Dr. Shikhar?
Sir, sorry, sir.
Yeah, you can stop sharing that one. No?
I have,
from your end.
sir, I'm not
Then,
sharing, sir. I have stopped.
okay. So anyone, I think, are you able to share? Hello? Hello?
Sir, the tech team is facing some issues, sir. Allow me a moment. We're trying to fix
Yeah.
it.
Yeah, just okay. Man, I'll wait. Hello.
Yes, sir. One more moment, sir.
No problem. Just I have logged in from my laptop. If you could allow me to share from my laptop, but you have to make me as a panelist. Then only I can share that one. Of course, I think just at the beginning now. We can start discussing that one. I think thank you for your wonderful presentations from Dr. Rajni Priya, Dr. Paramjyoti sir, Dr. Rajesh, Rakesh, and Shikhar Kumar. I think really we have gone through something like a lung cancer management from the diagnosis, especially Paramjyoti sir clearly mentioned. Sir, Paramjyoti sir, I think just I would like to ask any question, some few questions. I think some people nowadays, the people they are saying liquid biopsy is almost equivalent to tissue biopsy. Still, do you agree or do you disagree with that statement?
Haha. Yeah, no, but biopsy, first of all, it's so expensive. And if you get a positive diagnosis, that's fine. But if negative doesn't rule out that everything is fine, so you still have to have a tissue. So
Yes,
wherever possible, I think tissue should be the uh, mm, it should be the procedure of choice. Get the tissue so that you can study. Now various platforms are also available, so you can study co-mutations and all those things, DNA based, RNA based, all those things are there evolving. So I think tissue, PDL1, I mean, all these things, tissue is the only thing there. So I still feel if tissue cannot be obtained for some reason,
yes.
maybe that's the only situation where you can get a liquid biopsy, but otherwise, I think tissue should be the should, so tumor,
I think, yeah,
transformation to another malignant small cell cancer, and all those things. I think tissue is the better one.
yeah. I think yes. So always, I think tissue is the ideal way. I think sometimes nowadays people they'll say the combination of both will give us because so many targets, NGOs. I think so many targets. I think we have, but some of the things I think we can't get through this one. What I can say, our NGS. So some amplification,
Yeah.
some co-amplification, overexpression of RNA because sometimes overexpression. Sometimes these are the things we can't get everything through this one. Dr. Rajni or Dr. Rakesh, anybody you can, this people they'll say, okay, you can get away with this liquid biopsy. What is your opinion now?
Hello.
Yeah, ma. Yes, ma, Rajni.
Sir, liquid biopsy, especially a diagnosis when we are going with the for resectable lung cancers, maybe definitely no, sir. Maybe in
Yeah,
metastatic setting, that too, at progression, we can consider liquid biopsy, but not in upfront setting at diagnosis, not in either resectable or in first line, maybe definitely not.
yeah, yeah. Rakesh, I think, do you have any difference of opinion? Mhm.
Yes, I think I would largely agree with Dr. Rajpriya. Basically, what we are looking at is a combination of tissue and ctDNA as a standard of practice where it is available as per NCCN and any other guidelines. It increases the uptake of the identifying a driver mutation by nearly 50 to 20%. There could be situations in which we are going to proceed for definitive CTRT and we have probably a biopsy that was not sufficient for a NGS or inadequate for NGS. A profile fits for a driver mutation, but the NGS from the tissue is negative, and we are
Yeah,
proceeding with a definitive CTRT. In that situation, probably ctDNA can be done. In off case that we are missing a EGFR mutation or ALK mutation in the biopsy specimen, and we probably will not have a repeat biopsy because we are going for CTRT.
yes, definitely. I think whenever you're planning for something like, as I mentioned, so especially PDL1, I think we can't get through this again. Our liquid biopsy. Maybe tumor mutation burden we may get, but PDL1 expression, TPS score, CPS score, so many scores are coming up in this one. So better to have the adequate tissue, I think, where we can get complete analysis. So that's the way I think we have to coordinate with other, what you can say, something other multidisciplinary approach is most important in these things. So thank you again. So we'll go to the again was a small thing just I wanted to present, but ultimately what we have discussed here is we'll go to the next slide, please. Yeah. Yeah, I think lung cancer again now because we are running the tumor registry in Hyderabad as well as we're part of this ICMR project. Definitely lung cancer is the second most cancer in males. As you know, nowadays I think head and neck cancer is predominant one. When I started my career like 20 years ago, lung cancer was the commonest one. But now because of the usage of the tobacco changed from smoking to the oral tobacco, so that change has happened drastically, significantly to head and neck cancer, commonest one, then lung cancer. Again, the lung cancer is the definitely the second leading common in males, again, but on overall, it's the fourth most common. So next slide, please. So I think as well, already we had discussed as Shikhar Kumar and clearly mentioned is stage 3A, stage 3B, stage 3C. So to define this one 3A, 3B, 3C, I think we need to have the something like the proper diagnosis by either EBUS or IUS ultrasound guided because mediastinal lymph nodes I Paramjot sir clearly mentioned what are the characteristic features of malignancy and based on that only then they can sample that lymph node and ultimately the yield will be very good. So with that, even though the yield is very good, sometimes the rose means I think rapid onset site evaluation. That's the one I think we have to go through this one and to see whether the sample is adequate or not. So be here, I think what Dr. Rakesh and Dr. Shikhar, they have clearly mentioned that the adjuvant therapy. So in a resectable stage, before we do the surgery, I think we need to have the PDL1 status or Vatican's EGFR mutation status and all because all these three areas where we have some good therapies are available, we can prevent the recurrences in the future. And okay, now this from resectable to now we just wanted to move to the unresectable stage 3B or stage 3C. So there is not a U unresectable, so we can't go for resection. So the standard of care at that point of time is the concurrent chemoradiation is the standard of chemotherapy as a standard of treatment modality. But again, even though we have given the something concurrent chemoradiation with definitive intent, but some people they may recur locally as well as the systemic relapses are very, very common. So there they wanted to give some therapy to prevent the future recurrences is known as consolidation therapy. That go to the next slide, please. The consolidation, I think the people, this is already it's a nodal stage involvement of Paramjot sir clearly mentioned the number of nodes and everything. So go to the next stage. Next slide, please. Yeah. So here again, the concurrent chemoradiation coming to the part, I think once upon a people, they say give the some form of chemotherapy, reduce tumor size, then you can go for this known as sequential radiation, concurrent chemoradiation. That was one concept once upon a time. Again, later again, the people they said no, better to start because it's a curable malignancy. So give the concurrent chemoradiation upfront. And there is known as concurrent versus sequential, and these are the some trials clearly they have mentioned concurrent chemo radiation is the standard of care. Definitely, all these are the statistically significant survival benefit with the concurrent chemotherapy. So go to the next. So again, the concurrent chemo radiation. Again, we have to think of what type of chemotherapy we have to give. Go to the next slide, please. So we know that one. This is a 56-year-old male patient with a breathlessness. Go to the next slide, please. So that what we had discussed already. The right upper lobe mass. Ultimately, it is something mild right pleural effusion, but they have said clearly there's a pleural effusion cytology was negative. So go to the next slide, please. So this stage 3B. So this is a poorly differentiated adenocarcinoma, clinical stage 3B. And no identified tumor mutations. Because there are no driver mutations, definitely we can go for chemo radiation. Go to the next slide, please. So the already we have planned the concurrent versus sequential induction definitive. So do you have any difference of opinion? Anyone? I think all of us, I think we know that one is So what is your preferred concurrent chemo backbone? I think any one of you, some medical oncologist from Rakesh or Rajni Arshika, do you prefer cisplatin etoposide, carbo, or something like in a paclitaxel? Any one of you can. Rakesh,
Yes, sir.
Dr. Rakesh.
Yeah, yes, sir. We are practicing most of the times the paclitaxel.
Okay, sir.
And,
So it's a weekly regimen or something like a
weekly
3
regimen of paclitaxel and carboplatin.
Okay.
And this goes on concurrent with the radiotherapy, especially for those who are having the performance status to at least sustain both the therapies. If there is a performance issues and there is a concern that they will not sustain the doses of radiotherapy, probably we'll go for a sequential chemo RT, where we'll be complete sometimes some amount of chemotherapy and repeat a scan. And if scan shows good response, we'll consolidate with some radiotherapy. So this is better than just chemotherapy and better than just radiotherapy alone.
Yeah. And Shikhar, I think what is your opinion? Some people they want to use a pemetrexed, carboplatin, and old timers we used to give only cisplatin etoposide. So, but what about your choice and what is your institutional practice is similar or do you give the PEM-CAR? Hello, Shikhar, Dr. Shikhar Kumar. Yeah. Or Dr. Rajni.
Yes, sir. So at Queens, we used to give cisplatin etoposide, and here also we give cisplatin etoposide. And for patients who cannot tolerate a cisplatin, we are giving paclitaxel, sir.
Okay, Amma. Yeah. Again, the cisplatin is 2 regimen, only 2 cycles, I think, no? Only 2 cycles.
Yes, sir. Yeah.
Yeah. Yeah. Okay. Dr. Shikhar, are you there?
PEM and
Yeah. Okay. Go ahead. Dr. Rajni, go
nothing,
ahead.
sir. Pen carbo I have never given, sir, but it's either the cisplatin etoposide or paclitaxel, which we commonly practice.
Okay. Okay, that's a big based on institutional practice, but all of them are accepted regimens in concurrent chemoradiation. So I think one thing, but to come in, definitely we'll get a good. Some people again the radiation dose. Go to the next slide, please. Some radiation dose also there is some controversies here. So these are the concurrent regimens. I think what we have discussed till now. But wind blast we don't use regular in India. All other regimens are acceptable. Go to the next slide, please. So coming to this one again, chemoradiation, always we said all the meta-analysis, everything that clearly shown that concurrent chemoradiation is better than the sequential. There is no doubt in that. So it increases the overall survival, PFS, there is no doubt. Go to the next slide, please. Radiation dose, and do you have any something like nowadays people, they have the different types of radiations or machines are coming into the picture now. So anybody has a difference of opinion on whether we have to go for 60 gray or 74 gray or the lesser because you are able to give the best chemotherapeutic agent, can you go for the lesser dosage? Anybody, any one of you can answer this. You can share your experience because
we either use 66 gray in 33 or 60 in 30, sir. We are not going up to 74.
Okay, madam. And do you face any something like any complications during the radiation because chemotherapy sometimes it increases the bone marrow toxicity or lung toxicity? Do you have any something like any breaks in between, or we can go ahead with the therapy, madam?
Usually we do assess the patient every week, once a day, every week, and depending upon the toxicity, we might have to reduce the dose of chemo. We try and get, I'm a clinical oncologist, so for my patients, I deliver both radiotherapy and chemotherapy. So what we practice is, our aim is to complete radiotherapy, the full, and tweak around the chemo dose as needed.
I think again, madam, I think we have in the panel also, there is a Lakshmi Deepthi is there and Dr. P. Venkateshwar Rao. And of course, Venkat Sampath also there. So do you want to share any experiences in these areas? Venkateshwar Rao, P. Rao, Venkat Sampath. Anyone do you want to comment from staging, radiation plan, concurrent chemotherapy arm? And next with the
weekly paclitaxel, generally if patient is having good performance status, they do fare well. I mean, they generally complete the schedule without much problem. we should not compromise either chemo or radiation here.
Yeah, so there are no issues. I think any regimen is okay for all of you. I think they're agreeing on that. So next, coming to here is again the problem. Next, we'll go to the next consolidation. I think all of you are more experienced oncologists. And did you try any of this consolidation therapies? Next slide, please. Consolidation means some people they used to give the chemotherapy, some people they wanted to give the EGFR blockers. Next slide, please. Yeah. So next slide, please. Yeah. Next slide. Yeah, the coming to the consolidation therapies, I think we have so many regimens we used in the past. Consolidation docetaxel, cisplatin, later something pemetrexed. So what is your opinion on consolidation? I think any of these, I think whether you tried in your practice or just we never.
Earlier we used to try, sir, but now that we have specific data with durvalumab
Okay.
and
Yeah. We'll go to the next slide, please. So because I think problem here is all these therapies, I think we tried a number of times in different areas, but all of them are futile. We never achieved a major benefit in terms of disease survival or overall survival. So go to the next slide, please. So with that, I think there is a remarkable change happened. Next slide, please. So in the management of this stage 3B cancers after concurrent chemoradiation, there's an immunotherapeutic agent that is coming to the picture. I think all of us, we know the immunotherapeutic agents, they work better once we have given any chemotherapy or radiation. The antigens will be released into systemic circulation, and ultimately they do better after some, along with the chemotherapy or after some time of these therapies. So next slide, please. I think then there is a study, the Pacific study, I think the Shikhar mentioned here clearly. Next slide, please. So this is a durvalumab, I think, entered the picture. So many trials entered. I think that's what I had discussed till now. All the drugs, other therapies that failed in the consolidation, other than this durvalumab. Next, please. So this is the one I think everybody we are talking about now, Pacific trial. So Shikhar Kumar, Dr. Shikhar had clearly mentioned. Next slide, please. So here is again the trial is, I think, clearly mentioned that when it's concurrent chemo, completion of concurrent chemo radiation, better to just start the therapy durvalumab within 42 days. So don't wait for again 2 months or 3 months to see the response, because we can't assess the exact response. So for example, if you want to do the PET CT, we have to wait for 6 weeks to 2 months, but here we can't wait, and there is a durvalumab, and this is a trial. Go to the next slide, please. So here is again, there's a survival, again, Shikhar Kumar clearly mentioned. Next slide, please. So this stratification between the placebo versus durvalumab. Next slide, please. All the stratification, they clearly. So you can see there is a significant benefit in overall survival and 47.52. Okay, something 29.1 over. Definitely, we can see the something around 1.5 year benefit in terms of this consolidation influence is known as something durvalumab. So you can see the curve separated from 1 year, 2 years, 3 years, 4 years, 5 years also at around 42.9%. People are still surviving. That means I think there is a significant benefit in terms of a delta benefit of 1.5 year with a survival benefit of around something around 9%. So with this hazard ratio 0.72. So definitely with this data, I think FDA and ESMO, everybody, they are given the approval for this durvalumab. Go to the next slide, please. So next slide, please. So these are all the responses, what you discussed. Next slide, please. Yeah. So overall survival and BFS benefit, everything, whatever you take it in all the subheadings like in a gender, age, smoker, irrespective of the histology, also sometimes irrespective of the PDL1 expression and geographical. So whatever you take it, and ultimately Durva has scored over this placebo. Go to the next slide, please. So first and only approved IO to demonstrate to OS and PFS benefit. Both, I think, it's a PFS of around 0.5 hazard ratio and OS of around something like in delta of 1.5 year. So with this, I think this we got the approval from this And we had one more drug in this armamentarium of stage 3B, post concurrent chemoradiation conservative agent. Go to next slide, please. So I think this is one, I think the respective PD-L1 status, what you have discussed, less than 1%, more than 24%. So, but of course, definitely we'll get the maximum benefit in the people who expressed more than 1%, even less than 1% also will get this PFS benefit. So go to next slide, please. So ultimately, this is one, I think, whatever we have discussed till now. So do you have any something comments on this one? Because durvalumab, I think, do you have any problem in starting therapy or giving this the drug? I think, do you have any something concern? Because the panel, like the next again, we have some discussions. We can discuss any of these panel members. They can comment on this study, as well as this any practical difficulties during the radiation, after radiation, and we have to complete therapy for 1 year. So any of the something, any issues you are going to face during this therapy, please, and any one of you can take up and get some part. Anyone?
Sir, it's a very, I mean, for me, durvalumab is reasonably easy drug to manage. Of course, we should be prepared for immunotherapy-related adverse events. Most of the times, what we see is skin rash and sometimes thyroid dysfunction. Other than that, it's relatively safe unless patient has some autoimmune issue and all. We use it unless we ever only if patient has an autoimmune history or so. Compared to Western literature where we see more IR adverse events, we have relatively less commonly we have seen.
Anybody has any something like some people the post concurrent chemoradiation, pneumonitis? I think that Shikari mentioned. Is it a concern, or can we predict, or can we prevent, or something? Or can we, Dr. Rakesh, Dr. Anila, madam? Yeah.
I think once we get a scan after a month and there is no much radiation pneumonitis after chemoradiotherapy, probably I think those patients are not any higher risk with pneumonitis for durvalumab. That's what I think.
And even the long-term follow-up data also suggests that in both the settings, it is about 10 to 12%. Those who are on placebo or those who are on durvalumab, there was no real increase in the incidence of pneumonitis because of proximity to radiation completion or any previous history of pneumonitis or something like that. Obviously, immunotherapy does have its own adverse effects, but that will kick in later. It is not a major problem in the early part of the maintenance.
Yeah. I think the only thing is we should be aware of nowadays. I think all of us, we are experienced in managing the side effects of immunotherapy very well. So, but problem is, I think, try to predict and prevent. That's the only way I think we can avoid the complications of immunotherapy. Please next go to the next slide. So our patient I think received the same concurrent chemoradiation followed by durvalumab. Next slide, please. So this you can see the good response. Ultimately, patient is doing very well. Now go to next slide, please. Yeah. So this patient received durvalumab up to 1 year, completed without any major problems. Next slide, please. So this again, because whatever I wanted to discuss is again same issues like MDT approach gives a best outcome for this patient with any stage. I think there's not only stage 3. Stage 1, we have to involve the surgeons. Stage 2, up to stage 3A, we can involve the surgeons. But any problem in mediastinal involvement, I think we have to involve our pulmonologist to see something in EBUS, and ultimately whether it is a bulky mediastinal. Any mediastinal node is not, Paramjit sir clearly mentioned, all mediastinal lymph nodes may not be the something like a malignancy. So whether inflammation or infection or malignancy, so we have to do something like sir clearly mentioned what are the characteristic features of lymph nodes, malignant lymph nodes, and infectious or inflammatory lymph nodes. So, but still we need to have some tissue diagnosis, at least cytology to prove or disprove that one. And concurrent chemoradiation gives better outcomes than RT alone. So RT alone, once upon a time, I think we used to practice, we used to give some chemotherapy 4 cycles, then whatever is left over, we used to give the radiation to that area. But those practices are gone now. So better to go for either concurrent chemoradiation than either RT alone or CT alone or RT or CT sequentially. So consolidation CT doesn't improve outcomes, and ultimately the first and only approved immunotherapy, the Durva, demonstrate OS and PFS benefit. So definitely we can, this is a big achievement in the management of stage 3B cancers, because still we can expect a cure. At the same time, we can prevent the future recurrences. So there's again, irrespective of the EGFR and PD-L1 status, we are going to get the maximum benefit. Thank you. Just we'll go to the next slide, please. Thank you very much for. I think anybody wants to comment, because this is a forum for multidisciplinary approach. We don't want to just discuss something like an oncology topic. So anybody can comment on any of these areas. Share your experiences. Ultimately, this drug is, I think, already all the guidelines, NCCN guidelines, ESMO guidelines, Indian expert guidelines, all of them, they have approved this Durva as a consolidative agent after post concurrent chemoradiation. But patients should achieve good response. If the patient progresses, don't try this one. So the most important thing is the patient should achieve some response. Then only we can proceed with the durvalumab. Thank you, and we'll go to the next session.
Thank you, sir.
Anyone, if you want to have any comments, please we can comment, and then otherwise we'll go to the next session. Because already time is, I think this time is overshot. So now I'll hand over this podium to Dr. Venkat Sampath. He is a well-known medical oncologist and senior medical oncologist in Apollo Hospital, Jubilee Hills. Now he is going to take us through this new idea. Already we have discussed surgery, concurrent chemoradiation, and adjuvant. Now whether we can give these therapies before we plan for any definite therapy, the neo Adura. So over to you, Dr. Venkat Sampath now.
Yes, good evening, sir. Thank you for the kind introduction. I thank AstraZeneca for this opportunity. So my slides are visible, right?
Visible.
Yeah. So today my topic is basically neo-ADAURA. So this is a trial wherein neoadjuvant osimertinib with or without chemotherapy in resectable EGFR mutated patients was studied. So the background is that neoadjuvant chemotherapy and chemo-IO are options for resectable non-small cell lung cancer. However, major pathological response rates with neoadjuvant chemotherapy and chemo-IO are low in EGFR mutated non-small cell lung cancer. So in this particular set of EGFR mutated NSLC, probably osimertinib in neoadjuvant setting could increase the major pathological response rates, downstage the patient, and improve the long-term outcomes was the premise of this particular trial. Additional advantages of effective neoadjuvant therapy are it reduces disease progression, precluding surgery, because with prior only chemo or chemo-IO, up to 15% of patients have progression, precluding definitive surgery. Improves surgical outcomes. Up to 60% of patients do not have lymph node downstaging with chemo alone, and improve long-term treatment outcomes, because up to 36% of patients may not receive adjuvant treatment. So in that setting, neoadjuvant treatment with an effective drug could have better long-term outcomes. And more effective neoadjuvant treatment enables patients to complete surgery and derive survival benefit of adjuvant osimertinib, which has been already demonstrated in ADAURA study. So phase 3 neo-ADAURA study explores whether neoadjuvant osimertinib with or without chemotherapy can further improve pathological, surgical, and long-term outcomes in resectable EGFR mutated stage 2 to stage 3B non-small cell lung cancer. So it's a global randomized phase 3 control study. In stage 2, the main patient group was stage 2 to 3B non-small cell lung cancer who had EGFR mutations and were resectable. So age above or equal to 18 years, histologically confirmed. Both, this is mainly adeno non-small cell lung cancer were included. EGFR sensitizing mutations of exon 19 deletion and L858R mutations only were included. And performance status 0 or 1. Patients were randomized into 3 groups in 1:1:1 ratio. So one of the arm received only osimertinib, ATMG, OD, that is monotherapy, and osimertinib along with chemo, either cisplatin or carboplatin and pemetrexed, or only chemo plus placebo, followed by surgery. And after surgery, investigated choice of adjuvant treatment. However, most of the patients received osimertinib, which was supplied by the sponsor. The primary endpoint was major pathological response, and the secondary endpoints were EFS, pathological complete response, and nodal downstaging and safety. So the baseline characteristics were more or less matched across all the three groups. So the median age was in 60s, and adenocarcinoma was the only patients mostly included. EGFR, exon 19 deletion, and L858R were included. Notes, all N0, N1, and N2, all the three groups were included, more or less balanced. And baseline tumor size was around 4 centimeter. So out of the three arms, 92% in osimertinib plus chemotherapy, 97% in osimertinib monotherapy, and only 89% of the patients in placebo plus chemotherapy went on to surgery. And R0 resections were higher in the osimertinib monotherapy, that is 95%, and 93% in placebo plus chemotherapy. So at least 91% of patients who completed surgery received sponsor-applied adjuvant osimertinib. And the serious adverse events causally led to surgery occurred in 10, 5, and 7% of the patients respectively, and no patients died within 30 days post-surgery. So when we see the reasons for not undergoing surgery, majority of the reasons is progression of the disease. So in chemo arm, about 8% of the patients progressed, whereas only 2% of patients progressed in the osimertinib arms, osi plus chemo and osi monotherapy. And when we see the major pathological response rate, which was the primary endpoint, it was 26% in osi plus chemo, 25% in osimertinib monotherapy, and only 2% in placebo plus chemotherapy. The difference is staggering of 23%, which is statistically significant with a good confidence interval. And this major pathological response benefit was seen across all the subgroups, whether it is age, less than 65 versus more than 65, male or female, gender, race, if smoking, yes or no, and EGFR mutation, whether it is exon 19 deletion or L858R. The magnitude may be different, but the benefit is across all the groups. And even central plasma ctDNA EGFR positive negative. So EGFR positive patients have had better benefit, but it was significant across all the patients. Similarly, OC mono plus plasma plus chemotherapy also demonstrated major pathological response benefit across all the subgroup of the patients. And the response depth was also more in the osimertinib arms, wherein more partial responses and more complete pathological responses were noted in the osimertinib arms compared to the chemotherapy alone arm. So over 50% of patients with baseline N2 disease were downstaged at surgery with osi containing regimens, which is quite significant. So in placebo plus arm, it was 21%. So it's almost doubly 53 versus 21% in terms of nodal downstaging. And interim EFS analysis with 15% maturity only showed a hazard of 0.5 in osimertinib plus chemotherapy and 0.73 in osimertinib monotherapy. With osimertinib plus chemotherapy, it is significant, but this is not the time to analyze this one, but it's a trend. With MPR status, the patients who achieve major pathological response have better EFS. The correlation is with the MPR status. And regarding safety summary, it's comparable between the osimertinib plus chemotherapy arms when we see all adverse events and grade 3 adverse events. However, it is quite low in the osimertinib monotherapy. The grade 3 or greater events were only 13%. So the major notable events in the osimertinib arm are only diarrhea, whereas neutropenia, rash, constipation, etc., pancytopenia, anemia are more common in the chemo arms, whether it is osi plus chemo or placebo plus chemo. So the conclusions are neoadjuvant osimertinib with or without chemotherapy demonstrated statistically significant improvement in major pathological response rates versus chemo alone, that is 26 or 25 versus 2% in resectable EGFR mutated stage 2 to 3 B non-small cell lung cancer. Interim event-free survival trends favored the osimertinib containing arms with a hazard of 0.5. Fewer patients with a major pathological response had EFS events versus patients without major pathological response, that is 2 versus 18%. Over 50% of patients with baseline N2 disease were downstaged at surgery with osimertinib containing arms versus 21% with chemotherapy alone. Safety findings were consistent with the known profiles of the individual agents. So neoadjuvant osimertinib with or without chemotherapy should be considered when planning treatment for patients with resectable EGFR mutated stage 2 to 3 B non-small cell lung cancer. So the neo-ADAURA, when we see in the context of ADAURA, because anyway these patients are going to go to adjuvant osimertinib and would get survival benefit. But however, mainly the advantage would be some patients who may not continue to receive adjuvant, in such patients probably neoadjuvant addition would help, and we could probably downstage, and nodal downstaging may improve. And whether major pathological response in long term will have effect on the EFS and OS has to be looked into. So now it is not yet clear, but it can be definitely considered as a neoadjuvant option when we are considering neoadjuvant therapy rather than chemo or chemoimmuno in EGFR mutated non-small cell lung cancer. So with this, I conclude my talk today. Thank you.
And thank you, Dr. Venkat Sampath. I think again, we are now going for this neo also. Neo means neo adjuvant, whether we can give the therapies to decrease the size and make it more operable. So that's the way I think we are going forward. Definitely, I think in the future, I think what you mentioned, we have to think and practice change in the future. So thank you once again for all this speakers. Now I think again we'll go it for 10 minutes talk on methodological approaches to clinical trial data interpretation by Pagadala Harish. So over to you, Dr. Harish. Dr. Harish is there?
No, sir.
No. Hello. He's not there.
No, sir, he is not here.
So what about the next talk? Any this?
Due to some medical emergency, both the next speakers are not there. So now you have
Oh.
to conclude and closing remarks and yeah.
Oh, okay. So this I thought, I think just because it's in a program agenda, I think I wanted to just confirm that. Sorry, I could have confirmed before that. So I think again this is a wonderful discussion by Astra. I think very well designed this session, and I think you have involved all the specialists. One thing about is again that this management, I think over the period of 25 years, I think we have seen a lot of changes in the management of lung cancer. Definitely, I think we can do more now. So I think once upon a time from 5 months to now 5 years, the survival. So definitely we can see change in the management of this lung cancer. And without thanks to this pharma industry or research academic centers, they are doing a wonderful job in finding out and defining these all the targets, these important targets. So from broad chemotherapy from Paclitaxel carbo to now we are able to go for treat many patients with these target agents like EGFR, RAS, all now I think even KRAS also it's coming to the picture, immunotherapy. So ultimately I think especially these are the drugs, some of the drugs they may not penetrate the blood-brain barrier, but osimertinib definitely scored over other generation one, what you can say, first generation, second generation TKIs. So we are able to prevent the CNS disease, or we are able to treat even the asymptomatic brain mets also. It works, no need to go for radiation. So and again, the Durva also changed this management of again post-concurrent chemoradiation. Still, again, best therapy by one of the best therapies we have now to prevent the recurrences. And because once we have that is more active agents, we are able to use these drugs as an adjuvant now. It's approved, especially with osimertinib, and neoadjuvant also coming to the picture. Maybe in the future, again, post-concurrent chemo radiation also it's coming to the picture as Dr. Venkat Sampath as other speakers that clearly mentioned. So we don't want to reserve these best drugs for the later lines of therapy. So we wanted to use these drugs upfront and make them live better with a good quality of life as also is most important. And thanks to all the speakers, especially Paramjyoti sir, Rajni Priya, Shailesh, Rakesh, Shikhar, and Venkat Sampath, all of them have done a very good job. And thanks for this AstraZeneca for giving us the opportunity to share our experiences and some scientific content and trials also. And thanks once again. Over to you, Astra team now. AstraZeneca team. Thank you.
Thank you very much, sir. And now we are closing today's webcast. Thank you very much. Thank you.
Yeah. Thank you. Good night.
Thank you.